Welcome to the Patna Ops and Gynae Society program on RH Alloimmunization, Best Practices and Guidelines. So we have a galaxy of stars and a wonderful panel to discuss on the nuances of RH isoimmunization. So first, let me introduce Dr. Pragya Mishra, who is the Secretary, Patna Ops and Gynae Society, a Founder Secretary, Bihar Chapter of ISAR, Treasurer, ISOPARG, and she's been awarded many awards across the years. She's an organizing secretary for 24th BoxCon 2014 and a fantastic personality. Welcome, Dr. Pragya. Dr. Pragya, may I request you to introduce the rest of the panelists?
I think she said that she'll come in 2-3 minutes.
Dr. Abha, may I request you to take the on, please?
Excuse me?
Yes, Doctor.
Yes. I'm in.
Yes, madam, please.
So it's my pleasure to introduce the moderator for today, my dear friend, Dr. Deepika Deka. And she has many laurels to her credit. She has been the professor of All India Institute of Medical Sciences, New Delhi. But at present, she is the Vice Chancellor of Srimanta Shankar Deva University of Health Sciences, Assam. And she is also on the board of MCI, I know that. I want to add that also. And she has been a director also of All India Institute of Medical Sciences. So we all are privileged to have Dr. Deepika Deka as the moderator for today's panel discussion. I hope you have a great one. So thank you, Dr. Deepika, for joining us.
Thank you.
As a panelist, we have our President, Patna OBGY Society, Dr. Neelam. She is a vibrant and dynamic president. She is the Senior Consultant and Medical Director at Santati Fertility Center and ART Center, Arvind Hospital, Patna. She has contributed many chapters in books. She is a co-author in Kishore versus Kishoriyon Ki Baatein. She has attended various national and international conferences. She has been the chair of the Scientific Committee IMS, of the Scientific Committee International Conference on Critical Care, Treasurer Patna Menopause Society, and office bearer in Patna OBGY Society in different capacities. And she is also the chairperson of the Endometriosis Committee, Patna OBGY Society in 1718. Welcome, Dr. Neelam.
Thank you, Abha.
And again, now it's my pleasure to welcome the head of the Department of Nalanda Medical College, Dr. Professor Renu Rohatgi. She is the Vice President of Patna Menopause Society, Chairperson Quiz Committee, Patna Ops and Gynae Society, Chief Coordinator of EMOC, BMOC and CMOC. And also she has been a postgraduate examiner in various universities, Chairperson Cultural Committee. We always remember your beautiful dances and singing, Renudi. And she has published more than 30 papers in state and national journals. So welcome on board, Dr. Renu Rohatgi.
Thank you.
I think Pragya has come by now, or somebody else will introduce me.
I will introduce you.
I can do it for Pragya. Oh, Pragya has come back.
Yeah. I said that, I'll be back in a couple of minutes. I'm audible, right?
Yeah.
Okay, so I have pleasure of introducing Dr. Abha Rani Sinha. She's one of our esteemed panelists for today's panel discussion on RH alloimmunization, best practices and guidelines. So she's the professor and of Department of Ops and Gynae at Muzaffarpur Medical College. And you all know that she was the chairperson of the Quiz Committee of FOXI from 2015 to 17. She has also remained the president of Patna Ops and Gynae Society from 2017 to 18. And well, there are lots of things like, she's an executive committee member of ISOPA, and she has, she's a master trainer for FOXI Demo, published papers in national and state journals, contributed chapters in FOXI publications, and
आवाज ठीक नहीं आ रही, ब्रेक हो रही है।
And she is a UG and PG external examiner in different universities.
Better.
And now we have Dr. Himali Heidi Sinha. She's a professor and head of the Department of Obs and Gynae, All India Institute of Medical Sciences. Well, her professional interests are in maternal fetal medicine, social obstetrics, obstetric epidemiology, and preventive oncology. She is a WHO Fellow in High-Risk Pregnancies at AIMS New Delhi, then WHO Fellow in Epidemiology and Medical Statistics, London School of Hygiene and Tropical Medicine, Master Trainer of EMOC, BMOC, SBA, IPAS, publications in national and international journals, contributed chapters to books, co-edited Prognosis and Treatment in Obs and Gynae. I think even I was a part of that book, undergraduate and postgraduate examiner, member expert group on preparation of guidelines, Ministry of Health, Family Welfare, and chairperson of the local committee, Clinical Research Committee of Patna Obs and Gynae Society. Current tenure. And our next panelists are head of the department at Indira Gandhi Institute of Medical Sciences, Patna, worked as craft service examiner for ND in MCI assessor, DNP examiner, and selection panel of UPSC, ESIC, etc. We have Dr. K. Manju. She's a professor at Patna Medical College Hospital. She's an executive committee member of Patna Obs and Gynae Society and a past joint secretary of Patna Obs and Gynae Society.
हाँ शांति दी शुरू हो गया है.
So I invite our esteemed moderator for today, I think we have introduced all the panelists, am I right?
Yes.
Yes, really.
Yeah. So we have our esteemed moderator for today, who is Dr. Professor Deepika Dekka. And the best part is, it's a real pleasure indeed, reconnecting with her, I would say. Because, well, of course, virtually, not really. Last time when she visited Patna, that was in 2018, she was a faculty for my GFM Con 2018. And well, and it is, and everyone, and I think today, we are going to have a lot of attendees because Dr. Dekka, people are quite excited, that because you're being associated with Voxy after quite a while, so I think a lot of attendees we are going to have and lots of questions because, you're a master on intrauterine fetal transfusion. And let me tell you, Dr. Dekka, as when she was the professor and head of genetics and fetal medicine unit at AIMS, I believe they did hundreds and hundreds of intrauterine transfusion. So, that couldn't
Thousand.
be yeah, that's what I'm saying, thousands, hundreds and hundreds. So I really thought, that there couldn't be a better person to moderate this panel other than Dr. Professor Deepika Dekka. I mean, the topic is RH alloimmunization best practices and current guidelines. And that's the reason, Dr. Dekka, everyone is so thrilled, you are back.
My pleasure.
And
My pleasure.
Yeah, and people have been, sending the flyers also back to me and saying congratulations and all that. And obviously, I think it's because of you that you are connected with us at Patna Obs and Gynae Society TOG webinar today. So with this, so good afternoon once again. Our all the attendees who have logged in, and I'm very sure that because it's just 10 past 12, and very soon we will have a lot more people logging in, and we'll have a good round of question answers as well. So now that all the panelists have been introduced, and I think Dr. Abharani Sinha introduced Dr.
Nothing wrong.
So now we will start with our first, we'll start with the panel. So I would request Dr. Decca to share her screen, the green button at the bottom. So if you could start sharing your screen.
Okay. Is it okay?
Yes, yes.
All the panelists can see?
Yes,
Yes.
Okay. Thank you, Pragya, my good friend, for inviting me. Going to Patna has always been a pleasure, and especially when your mother was there. She had invited me several times, the whole group, and it's really a pleasure. I'm sorry, I've been very, very busy because of the COVID. And but today, I've made time, and it's really a pleasure. Nice to see Abha and everybody else. Welcome. So to make the discussion very crisp and useful, let us have very crisp and to the point answers. And so can we start now? All the panelists, thank you for coming. So what I'll do is I will post a question, and anybody can answer. We can just go in one order. So the first question basically is just an introduction. So all the delegates who have come are definitely doing RH grouping. That is the first thing, one of the first investigations we do when a pregnant woman comes to us for booking. So then if it becomes RH negative and the husband is positive, then what do you do? What are the chances that the baby is going to be RH positive? So can we start with Dr. Neelam?
Thank you, Dr. Deepika. Am I audible?
yes.
Yes.
Yeah. If the woman is RH negative and the husband is positive, then the husband, if he is homozygous, then the chances are that none of the babies will be, all the babies will be positive.
Yeah.
But if the husband is heterozygous, then the chances are that it will be 50-50.
Yeah. So there's a 50% chance. The problem is,
50 will be positive.
yeah, the problem is we cannot do zygosity very thing. So we should take it as that all patients are, RH negative needs to be monitored. Sometimes if the baby is positive, there are situations where the RH isomerizations can occur even in the first pregnancy. Usually it happens, the first pregnancy is not at risk. It is after second pregnancy onwards when you don't take anti-D, or there are certain events that there can be immunization. So can you tell us, Dr. Renu, what would be the situations and causes of RH isomerization in the first pregnancy? Hello? Dr. Rohatgi, is there? Okay, Dr. Abha?
Yes, Dr. Deepika, well,
Yeah.
if a RH negative woman has received RH positive blood, then she may be sensitized even in her first pregnancy.
Yes.
And the other condition is sometimes we have heard of grandmother theory. That is what happens if a RH positive woman, she has a RH negative fetus, female fetus, then at that time there may be some transfer of the maternal blood to the fetus. And when this girl, she becomes a mother, she may have the antibodies right in her first pregnancy or even before her pregnancy. And that because of this antibodies coming from her grandmother, she may be sensitized even in her first pregnancy. So these are the two situations. Rarely after transplant also a woman may be sensitized even in her first pregnancy.
But can I add something?
Yeah.
See, if the first pregnancy there is history of silent bleed, or there is history of amniocentesis or placenta or external cephalic version, or there may be history of IUD, then even in the first pregnancy, the patient can get isoimmunized.
Yes, if there is, and sometimes, so this abortions, they go unrecognized also. They think it is delayed periods, and very often we have found in our practice that the patients don't tell the truth also. That's besides the point, of course.
Can I add something?
Yeah, sure.
If there is if the blood components has been transfused in emergency, like in dengue and all, then also it is supposed to be, sometimes it gets
yeah, but usually they are not.
But
they are quite because it's grouping is
right.
So that can be some. So even in the first pregnancy, we must do the ICT.
Yes.
Even in the first pregnancy, we must do the ICT. Okay, now let us go to case discussions, because our topic is best practices case discussions. Here is a patient, Dr. Shall we go to Shemali? That there is a second gravida. She's got one living issue, 12 weeks pregnant, A negative at antenatal registration. She's 12 weeks pregnant. And what will you do? She's come to you for the first time in the second pregnancy.
Yes, I'd like to take a complete history, and I would also like to know the husband's blood group, and would like to know the blood group of the previous baby and whether she received anti-D at that pregnancy or not. And now besides the other routine investigations, I would also like to do an ICT titer for this patient.
Yes. What are the things that you want to know about the previous pregnancy?
I want to know whether the baby was negative. If it is not negative, it was a positive baby. Did she receive anti-D or not?
When did she receive anti-D?
Well, in the antenatal period and postpartum.
Yeah, antenatal period when? I mean, we will be discussing that.
Okay,
but
right.
Now that we are taking the history, see, if a person gets just postpartum, then what is the risk that she will be immunized? And if she does not get antepartum, then what is the risk? Anybody?
Yes, I can take this question.
Yeah.
If the patient receives only the postpartum dose, am I audible?
Yes, audible. But not very consistent.
If the patient receives only the postpartum dose, then the isoimmunization falls to 2%. And if she takes an additional 28 weeks dose, then it falls 2.2%.
It becomes much lesser. So you know that you can, from the history, you can make out that the risk, how much it's going to be. Okay. What else you will do? You will do the ICT, you said.
Yes.
Yes, universally, we must do the ICT. So detailed obstetric history, I just wanted you all to say that, a history of some cases, in spite of taking the anti-D, they can get immunized. In fact, when I was working in AIIMS Delhi, 50% of the patients had received anti-D, but they were immunized. Why? Because they had retained placenta, manual removal of placenta, or they had very heavy fetal-maternal hemorrhage. So one injection of anti-D was not adequate. So there are many reasons, placenta previa, accidental hemorrhage. So these are the conditions in the detailed obstetric history where you see a woman can be immunized in spite of taking anti-D. I hope the delegates who have come, it is clear to them. So you really need to take a very detailed history. Caesarean section also increases the risk. Yeah, especially if you've cut through the placenta. And in cesarean, we have this habit of taking out the placenta manually. We just don't wait for it to separate on its own. That is a very bad thing you should not do in cases of Rh negative woman. Yes, we should also wait for the placenta to separate and with the cord hanging down. So at cesarean, we really don't do all these things. So these are some features. Okay. So you said that the ICT we will be doing at 12 weeks. Yes, everybody agrees?
Yes.
First antenatal visit.
It has come negative. What will you do again? Second pregnancy, Rh negative, ICT negative at 12 weeks. When will you do again?
Then at 28 weeks.
At
28 weeks.
Pardon?
At 28 weeks.
Why not before?
Because usually
somebody said 4 weeks. I heard that somebody said do every 4 weeks.
Monthly it should be done up to 24 weeks. After that, it should be done at an interval of 15 days.
If it's negative, then
yes.
If the patient is primary,
can we have one person answer? I can see Dr. Neelam saying something. If it is negative,
if it is negative in the first pregnancy,
patient is primary.
No, this is a second gravida.
Patient is second gravida.
We are talking about the second gravida.
Second gravida, okay.
Yeah, she has one issue. Now she's 12 weeks pregnant. ICT is negative. When will you do the next ICT?
At 20 week of pregnancy?
No, it should be done. It should be done monthly till 24 weeks.
24 weeks. After that, at a 15 days interval. After 24.
No, and this is not like antenatal care that you have to do it like that. See, we take 4 weeks. Earlier, some of the books and even Foxy guidelines have written. I remember seeing that it was written in the earlier one that you do at booking and then you do it 28 weeks. It is not. You see, second gravida, because of many reasons, they can get immunized. I have had many patients who got immunized during the pregnancy, landed up in high drops also. So we should do 4 weeks. Why 4 and not? Every 4 weeks we should do. So if she's done at 12 weeks, then you do again at 16 weeks and for 4 weeks. And after 32 or 36, we don't have to do again because you will give antidina. So once you have given antidina, so it's not that you have to do every 2 weeks. So please do every 4 weeks. 4 is taken because it is that in 4 weeks nothing very dangerous is going to happen. And even if you get somebody is having ICT, you can positive, you can refer. So please do every 4 weeks up to 32, 34 weeks when you will give the anti-D. After giving anti-D, do not do ICT. No need. Any questions? Yes?
28 week. Up to 20 weeks or 32 weeks.
No, we will talk when we will give the prophylactic anti-D. Okay?
I think if it is negative, Dr. Deepika, just to clarify.
Before that, before 28 weeks, we have to
one
do
by
the
one,
ICT.
please. One by one, please. Abhavya.
Yeah. So what message we are giving that if a patient tests negative, then also we have to repeat the ICT every 4 weeks till 28 weeks. And if she is negative at 28 weeks, we
the anti-D is given. We will talk about
give her a shot of anti-D. And then there is no need of doing further ICTs.
No need because you have given prophylactic.
Already she'll have antibodies because of the
because of the but that is usually about 1:4, never more than that.
Yes.
Clear?
Yes.
Okay, we go to the next question. Now you have done the test at say about 16 weeks and it comes out to be 1 in 8. She had some threatened abortion, she had some problems. Now it is 1 is 8. Are you worried?
Yes.
Yes.
Why?
Can I?
Why? Dr. Neeru, where are you?
Yes.
There is chances of fetal infection, but not.
Dr. Neeru, the photo
There is one.
Dr. Neeru.
Yes,
Neeru's photo I can't see.
No, now you can see.
Yes. So ICT is positive 1 in 8 at 16 weeks when she came for the second test. Now what to do? Are you worried?
Now we will repeat the test at after 4 weeks and see the titer and see how it is behaving.
Are you worried?
It is increasing.
Yes,
I am worried because it is more than 1:4 and 1:8 is now like lower limit of being increased.
Yes. So different laboratories have different titers, different places. So where I was working in AIMS, we had a cutoff of 1 in 16 as the critical. So Dr. Manju, what is critical titer?
The critical titer is that titer below which there is a very low risk for the development of hydrops fetalis or hemolytic disease of.
So usually what is the level?
Usually it is 1 is to 16 to above that.
1 in 16, some laboratories where I have heard. I used to have 1 in 32 also.
Or NTD level more than 10. Or NTD titer more than
So even if it is 1 in 16 or it is 1 in 258, it doesn't make a difference. Baby is having problems, may have problems. Okay. So in 1:8, we have to certainly keep we mustn't do middle cerebral artery peak systolic velocity and monitoring right now. We just have to monitor by ICT.
And one thing,
can I talk to Pragya, please? Is Pragya here? Okay. So I was wondering whether she would like to ask anything.
to add one thing.
Yes, Dr. Gurotki.
I just want to tell that this patient should be informed, may be referred to a higher center in cases of antibody.
Yeah, certainly. You know, the earlier we counsel, in fact, when an RH negative patient only comes, that time also you should counsel a little bit. But
the facility for the transfusion will be available.
We mustn't scare them, but we must say that your risk because of the negativity is this much. There is a 2% chance, there is a 0.2% chance, all the things we have to counsel. Okay. Now, what are the chances of, if the titers, whatever we do, there is a chance of the hemolytic disease in the fetus and the newborn. What is the chance? We already said 2% and 0.2%. We discussed about 0.8%, depending upon the antibody. Is there any other factor which increases the risk?
Yes.
Certain factors will increases the risk.
Increase the risk, yeah.
Volume of the feto-maternal hemorrhage. Volume.
What factors will determine the prognosis and outcome of the baby? Yes, increasing the risk of getting immunized.
First of all, the age of the gestational age.
How?
Gestational age of the duration of the pregnancy.
Second, how will that be risky?
As the pregnancy increases, the volume feto-maternal hemorrhage chances of that is increases, that and the fetal infection chances will increase.
Yeah, okay. But more specifically, is there any procedure? Is there any obstetric risk? Any other risk factors which will increase the chance of fetal-maternal hemorrhage, which will lead to immunization?
Yes. If there is any intervention being done in any form, either
the first trimester and second trimester.
Yeah, Dr. Neeru, please, yes.
If any intervention is done, that will increase the chances.
Yeah, such as
the
CVS.
Dr. Neeru, one by one, please. Dr. Neeru's turn, yeah.
In the first trimester, if we are doing amniocentesis or chorionic villus sampling, and
we are doing chorionic villus sampling in the second trimester. Amniocentesis in second trimester. First trimester, we can do CVS.
CVS.
So one is CVS, amniocentesis, any other problems?
Second trimester.
Even the ruptured ectopic, if it is there, then that will increase the chances of.
Yeah, okay, that's a risk, but it's a low risk, yeah.
And
any other thing?
External
abortion.
The first trimester is spontaneous abortion.
One by one, please. Who said external cephalic version?
In the second trimester.
In the third trimester.
No, first and second trimesters, external cephalic version is done towards term. We don't have to worry so much.
Threatened abortion.
What about threatened abortion?
Yes, threatened abortion.
If the threatened abortion with live fetus.
Threatened abortion with live fetus, should you give anti-D?
No.
Yes.
If the bleeding
is where is the
beyond 12 weeks?
There is this bleeding, no? So fetal-maternal hemorrhage will occur. You should give anti-D because those cells, how immunization occurs. Can we go to the pathology? Whose turn is it? Dr. Abha, can you tell us exactly how immunization occurs? Then people will understand how threatened abortion can cause.
Yes, whenever there is a breach in the choriodecidual space, that will lead to some transfer of the fetal blood into the
RBC, yeah.
And what happens in threatened abortion, if there is persistent bleeding, if the gestational age is close to 12 weeks, and if there is associated abdominal pain, there are more chances of increased fetal maternal hemorrhage. And again, if we do any surgical procedure, like if we
let us speak to only threatened abortion. We have already talked about amnio-CVS. So please remember that threatened abortion also can cause. So people, because when there is bleeding, especially when there is bleeding and you have seen the cells are fetal RBC, the red blood cell will go to the maternal circulation.
Maternal circulation.
Will excite the immune response, antibodies will form, which will cross over to the baby. So even threatened abortion is a risk. So as we already said that the procedures increase the risk, and the risk increases with the gestation because of the thinning of the placenta barrier. So let us go to the next case. I think Dr. Hemali. This is a primary at 6 weeks pregnancy with spontaneous abortion. Now she has aborted. Do we need to give anti-D?
Madam, I just wanted to add one thing. Hello?
Dr. Hemali, who's speaking?
Yes. Yeah. At 6
Hello,
weeks.
Pragya, I was looking for you. Yeah.
At 6 weeks of.
Yes.
At 6 weeks of gestation, B negative with spontaneous abortion, the guidelines say there is no need to give anti-D, but because the chances of fetal maternal hemorrhage and isoimmunization is very low, but explaining to the patient and saying that there's a very negligible chance, but there is still a slight chance, I would, in my practice, prefer to give her a low dose of anti-D,
yes,
just to, so that she's not that one in, even that 0.1% chance is not there.
Yeah. Others agree?
Yes.
Others agree? Yeah.
Yes.
You see, the RBCs are formed by day 21. Antigenicity will be low, but the rule of the thumb is, when in doubt, give.
Always give.
Yes.
6 weeks.
Who's asking? Somebody's
There is the
asking.
chances of development of NTZ.
Okay. Yes, who's asking? I can't see the face.
Pragya.
Oh, Pragya, okay. Yeah, I was looking for you, Pragya. Please let us interact also.
No, I just wanted to reiterate what Dr. Hemali Sinha just mentioned. Because even our COG guidelines and all, they say that if there's a spontaneous miscarriage or if it's, threatened miscarriage by no intervention under 12 weeks, they are saying that, there's no need for anti-D. But the problem is, none of us want to take a chance,
Yes.
So
Not just chance. Even there is proof. We have had lots of patients, and we know that there is always some amount of fetal-maternal hemorrhage even at 6 weeks,
Which might.
which might cause problems later on.
Even
RH antigen is present on the RBC at 30 to 40 days after.
20
at
years.
about
Day
5
21.
weeks.
The
At about
antigenicity
5
is
weeks
present
of
there.
gestation.
Antigenicity is very low actually. Before 16 weeks, it's low. So if somebody cannot afford, don't really pressurize and say that nahi ho hi jayega. A risk is low. Those who can afford,
Still there is risk, but still there is
it's
risk.
very low risk. We have sometimes
The risk should be mentioned. The risk should be mentioned.
The risk should be mentioned. Yes. Okay. So we go to Dr. Neeru. This is a gravida 2, para 1+1, 7 weeks ruptured ectopic pregnancy, something like this only. And surgical intervention has been done. So do we still need to give anti-D?
Yes, we will definitely give, and we will give a complete 300 micrograms of anti-D.
7 weeks only. It's almost very low.
So 50 to 100 micrograms.
Yes, I agree that it is just a 0.1 ml of blood that might have leaked.
Yeah.
But still, I will like to go for 300 micrograms.
I think 300 is a little too much.
150
microgram is enough.
Just like 6, below in the first trimester, we can just give anything between 50 micrograms. The thing is, whether the pregnancy is intrauterine or the pregnancy is in the tube or anywhere else, it is the RBC which will enter the maternal circulation, even through the other vessels, not through the ovarian vessels. It is not the uterine vessel which is carrying the blood, but other vessels also will carry the blood. In fact, sometimes even the peritoneum, the fetus is in the peritoneal cavity, or when blood, RH positive blood spills into the maternal peritoneal cavity during cesarean, even then you can have immunization because the cells are getting absorbed. So even when you're doing a cesarean, you should pack the intestines because then immunization can occur. So even with ectopic pregnancy, or whether it is in the tube or whether it is in the abdomen, there might be a low, because it is only 7 weeks, the risk is very low, but we can give a 50 microgram dose. Agree?
Madam, do we get 50 microgram?
It's not available.
I know it's not available.
150 is available.
It's not available. No. Yeah. So, sometimes folic acid, 4 milligram is not available. We are giving,
we are giving 5 milligram.
0.4 milligram is not available, but we're giving because the higher dose will not harm, but it is more costly. So if you can, you have another patient also sharing, you can share.
Yeah.
So interesting discussion. I wonder if there are any notes from the audience, Pragya. I was told that there were some chits, questions are pouring in.
We will be dealing with the questions towards the end. Once we are
towards the end? Okay. If it was related, I was thinking that maybe. Okay, now. Next case is for, Dr. Manju. Gravida 3 at 18 weeks, incomplete abortion. We get this very commonly. Then what is the dose? Is it 50 milligram or is it more than that?
300. 50 to 100 milligram is enough, but still, in some books written that it is after 12 weeks, 300 microgram of NTD should be given.
No. Up to 20 weeks, we can give 150.
What we say is
50 to 100 microgram is enough.
It is 150.
150.
But if you suspect that the leak is more and there may be more feto-maternal, then you can do a Clay-Hawes test and quantify the disease and then give accordingly.
How will you know in an 18 weeks pregnancy that the bleeding is more? Feto-maternal hemorrhage.
Maybe you have to do manual removal of placenta because this is normally the placenta which is retained.
Yeah, yes. So I think we are becoming more and more expert. That's very nice. So, sometimes you have to do this manual removal or you do a curettage or then in those cases, you think that the risk of feto-maternal hemorrhage can be much more and 150 may not be adequate. Otherwise, we generally don't give a full dose.
300.
Any queries at this point? Yes, Pragya.
Yeah. Kamna, just wanted to clarify that's for our attendees because, people, they just get confused with the units. Whether they mean to say micrograms or they mean to say international units. So I just want to
Anybody would like to answer from their question? Any of the panelists?
100 microgram is equal to
300 microgram is
units.
really written.
Yeah, I think microgram is the one that should be used.
100 micrograms is equal to 500 international units.
No. So you take microgram, just stick to one. All the Rogram, the others, they all have
preparing the vials in the microgram.
Yes. There is another question now. We shall go to Dr. now. Pragya, would you like to answer anything like routine antenatal dose? This is something, I found that there was some confusion, and you being RCOG person, I think this will be good for you to answer. We discussed a little bit. Dr. Pragya.
What? Yeah.
Can you hear me? Yeah.
Yes,
routine antenatal dose, single dose, double dose, confusion. If you could tell.
Yeah. Fine. Yeah. So, we should give. In fact, while I'm talking, there are people from the audience, quite a few questions. And they are asking that, should we give to everyone and when should we give, and now that, we are dealing with this question. So, you have to, for any RH negative, we have to, practice giving routine antenatal anti-D prophylaxis. Now, the question is whether you give a single dose or you give a double dose. Now, if you're giving a single dose, you give it at 28 weeks and you can give, 300 micrograms, which is equal to 1500 international units of anti-D. If you're have the practice of giving double doses, then in that case, you give one at 28 weeks and the second dose at 34 weeks. And in those circumstances, you don't need to give such a high dose of, 1500 micrograms. You can give 500 international units at 28 weeks and then 500 international units at 34 weeks.
I think it would be better if you talk in terms of micrograms. Yeah, I know RCOG gives 2 doses. So it is about the society. Foxy, when I was the chairman of the genetic committee, I had written that we give 1 dose because our patients come, you know. I don't know now what is, whether it's been printed or not. I have not seen. But at AIMS, we give 1 between 28 to 32 weeks. We give full dose.
Even the NICE guidelines now recommend single dose.
Single 28 weeks.
Our patients don't even come. You know, the idea is that sometimes that is enough, but it's convenient to give 1 dose.
So that's what. So if you're giving 28 weeks, just something to add. It's just that if the pregnancy exceeds 40 weeks, which we should never do, then you have to give a dose at 40 weeks.
No.
Doses with that.
No.
Actually, NTD works up to
1 injection of NTD works for 10 weeks.
12 weeks.
It covers for 10 to 12 weeks.
Yes.
Yeah, it covers for 10 to 12 weeks. So we time it like
up
that.
to delivery. 28
And
weeks.
you know, 48 weeks it will cover. And then after that, we do the post-natal. So post-delivery immunoglobulin dose. How do you decide about this dose?
No,
Dr.
excuse me, if we have to give 1 dose, then it should be only at 28 weeks and then
anytime between 28 to 32 weeks.
30 weeks.
See, we want you can give this 1, so that it will cover for the rest of pregnancy.
It works for 12.
Yes, if the baby is not is negative, then also it doesn't matter.
Actually, you don't know whether the baby is negative or positive. You don't know whether the baby is negative or positive.
That's why.
So we give it irrespective of the blood group of the baby.
Status of the blood.
Okay. That will be the routine practice.
One thing, provided the patient is ICT negative.
We have said only. We have said only that if she has to be ICT negative, then only we give. If she's positive, she can be a donor for immunoglobulins. So a lot of people used to do that. They will, before referring to me, they will give one anti-D injection and then send them to me. It's not necessary. Once a patient is immunized, no anti-D. No anti-D. Whether she is 1:8, 1:16, no anti-D.
I just wanted to clarify one more thing, Dr. Decker. The thing is that because in India, we have preparations which contain 300 micrograms. The reason, why the outside guidelines, the international guidelines, why they are saying about 2 doses, because a lot of countries, they don't have the 300 microgram dose.
Yeah, they have
recommend a lower dose at 28 and 34 weeks. Whereas for us, since we have 300 micrograms, which is enough to cover a fetal-maternal hemorrhage of 15 ml of blood.
15 ml.
That's enough, 300
Yes.
micrograms.
Let me tell you from my experience. When Dr. Bakshi and we were managing a patient, she had placenta previa and she kept on bleeding, and we could see that the baby was definitely baby's, middle cerebral artery was going because of anemia, not because of immunization. Mother was losing, baby was losing. We gave that baby, mother, more anti-D during pregnancy because we knew that fetal maternal hemorrhage was more. Massive placenta previa, you see.
Request to the panel, if anybody wants to say something, please raise your hand. Because just raise your hand, whoever wants to speak.
Yeah.
Okay, so that we don't have 2 people talking at the same time.
So post-delivery immunoglobulin dose, Dr. Neelam, any guidelines for that?
Post-delivery immunoglobulin should be given within 72 hours, and that is 300 microgram.
But you will do the baby's blood group first.
Can be given up to 1 month.
The baby's blood group should be given. You ask the dose.
Baby's blood group first. Sometimes people don't even do the baby's blood group. So when an RH negative patient has been delivering, what are the samples? I can see Dr. Renu there. Next person. Dr. Renu, when a patient is delivering, this is not in your thing, but what are the immediate investigations that you should do?
We should take that cord blood from the placental, and that should be for hemoglobin, hematocrit, serum bilirubin, and direct Coombs test.
Yeah, we must do the RH grouping that time. You know, a lot of people 7 days like they don't even have the baby's blood group. I have seen it, okay, but even supposing you get the baby's blood group positive on day 7, what will you do?
Single entity can be given, madam, up to 1 month.
Can be given.
Yes, it should be given. Dr. Manju, yeah, it should be given because, but it will be not so effective because by this time,
It is still effective.
within 72 days, 72 hours, these RBCs have reached the maternal immunoglobulin immune system and excited antibodies to form. So we should give as early as possible. Passive immunization, so we should give as early as possible.
Could I add something, ma'am?
Who's talking? Yeah, Nilam, yeah.
Dr. Himali. Dr.
The
Himali.
maximum
Okay, Himali, yeah.
up till so up till what dose at the max it can be given, and it has been found to be effective.
8 doses.
Necessary.
5 doses.
See, we know that just now Pragya had said that one injection of 300 micrograms will counteract 15 ml. So if you think that the fetal-maternal hemorrhage is more, you have to justify that. You do Kleho-Beske test. There was a question, we can discuss it now only. So when are the times, now it's turn of Abha, when do you think fetal-maternal hemorrhage is more? You know, you might think your entity is not enough, one injection.
Yes, if we have done a manual removal of placenta, even in C-sections, it has been found that the fetal-maternal hemorrhage is more. If she has been abruption of placenta, in all these cases, we suspect that there can be a large fetal-maternal hemorrhage. So in
Or a
these
very
cases,
large size placenta.
or a hyperplacentosis or a large size placenta, definitely.
Twins.
Or if it's a trauma.
Also in post-dated pregnancy.
Post-dated abdominal trauma, yes. So what we need to do in these cases, we should quantify the blood, the amount of fetal-maternal hemorrhage. So initially, Rosette test can be done, which can tell about the quantity, that if it is more than 2 ml, and then we can go for the acid dilution technique, that is the Kleho-Beske test, and that can help us to decide the dose of the.
So there are many tests. But
Kleho-Beske
is the
one
easiest.
step above the Kleho-Beske test. We can go flow cytometry gives a better result than the Kleho-Beske test.
Quantitative.
Yes.
That's quantitative.
But Kleho-Beske is something you can do in your lab very easily. Yes. So those high risk units must be having Kleho-Beske test. And so depending upon that, we have given. I have had patients where I have given even 3 injections of LP.
And even in stillbirth and IUD, the chances of leak is more. The hemorrhage.
Yeah, it all depends upon the amount of fetal-maternal. In fact, if it is an old IUD, there is no fetal-maternal hemorrhage. Sure. Because the blood is
calculated. Required. We give IV preparations. We give IV preparations if larger doses are required.
I couldn't hear. Who's talking? Who was saying the last? Voice.
Yeah. Voice is not very clear. I don't know why.
Yeah. Somebody had raised. Yes, somebody who's raising the question. Just raise your hand.
Dr. Deepika, I have one question for you. Now, like if we are giving 2 doses, what should be the interval between the 2 doses? And should it
Anybody
be
else wants
given
to
at
answer?
different sites?
Why? Okay, let me tell you to think why we are giving the 2 doses.
So we give just 1.
Why are we giving the 2 doses?
If the fetal
maternal
hemorrhage is more.
Fetal-maternal hemorrhage is more, so it is happening now.
If the patient is
continuing
continuing bleeding,
Same time. It has to be given then and there.
Not for the post-delivery case, I'm asking Dr. Deepika, like if a patient is bleeding, she's having recurrent episodes of bleeding. Can you get the question?
So, you are thinking that the bleeding is more, you give immediately.
In the antenatal
period. Because there is no, if you're doing Kleho-Beske test, you can do antepartum also. So,
and fetal blood, dose can be calculated by fetal blood into 5,000 divided by 1,000 of maternal cells.
Yeah, there's a longish formula. And so
that formula will
accordingly
divided by 30.
So Dr. Abha, I hope you understood that even if it is in the antepartum period, if you find that the fetal-maternal hemorrhage is more than 15 ml, RBCs, you give immediately.
And if it is recurrent bleeding?
Recurring also, no? So because you know that this much blood is going to cover for at least 8 weeks properly but you're supposing there is much more again, then you may have to give after 4 weeks, or you evaluate later.
6 weeks. Add something. The half-life of these
Is 16 weeks.
3 weeks, and therefore the dose should be repeated after 3 to 4 weeks.
What? Anti-D? No, it's 10 weeks. It will cover for 10 weeks. So when you give the prophylactic anti-D, it will cover for 10 delivery.
12 weeks.
Yeah. Yeah. Okay, shall we go to the next question?
Okay.
Yes. Okay. So now, Dr. Hemali, this is a gravida too with abruption at 34 weeks, having an emergency cesarean. Again, I think we have already discussed this. So this is one instance where, you know, fetal-maternal hemorrhage, especially the concealed type of abruptio, there is more cells. The pathology is fetal blood going to the mother. So all these conditions like abruptio, they disrupt the fetal-maternal barrier, and so the positive RBCs are going to the maternal circulation. Anything you want to add here?
Yeah, the tests we've discussed, that we can do the Rosette or the Kleiner-Becker, which are qualitative tests, or we can do the flow cytometry, which is quantitative. I'd only like to add one more thing here, which I wanted to say earlier, that if we have given an antenatal anti-D, the direct Coombs test should not be done on the fetal blood, because it may be falsely positive.
Falsely positive. Another thing, you know, is to look at the baby. If the baby is pale, you know, why is the baby pale? The baby has lost blood. You know, so pale baby also, you have to look at the baby. Okay, so now we go to Dr. Neeru. We have a patient who is Rh negative, ICT negative. Do we need to do ultrasound, Doppler? ICT negative?
No.
Why I'm saying is that people are doing.
No, if it is ICT negative, we need not do any ultrasound. We will do ultrasound only if the titer is positive or if it is increasing and it is reaching the critical level.
Yes. So what is the role of, you tell us what is the role of ultrasound? Don't talk about Doppler, just talk about role of ultrasound imaging.
By the ultrasound, we can see the thickness of the placenta, size of the placenta, and the baby, whether it is developing hydrothorax or ascites, or it is developing skin edema or scalp edema. If it is scalp edema, then the prognosis
those are very late signs.
Bad. So we should not ever allow for the scalp edema to develop, and we have to take the action much before that.
Much before. So there are other things also. Anybody wants to add? Just on ultrasound.
Yes.
You know,
can I add?
This is for people who are. Who is talking? Yeah,
Yeah. The first ultrasound sign that appears is fetal ascites. It is the first sign.
No, Dr. Abha, no. Ascites is very late sign.
Hydrothorax, pleural effusion,
any
pleural effusion and pericardial effusion, they come late.
Things are late. That is the first signs are, as Dr. Neeru said, placentomegaly.
Placentomegaly and placental thickness. In the fetus, the first cavity that is
you're doing ultrasound the whole pregnancy. You're doing everything. So, you know, polyhydramnios is another one we have to look at. So, anything, those things, polyhydramnios can occur.
And hepatomegaly is also one very important sign. Hepatomegaly.
Yes, hepatomegaly. And so these are, mainly it's hepatosplenomegaly, and also at the same time, you know, dilatation of the
cardiac.
Hepatic vein, the heart size, the cardiac size, these things are there. So before hydrops develops, hydrops also is divided into minimal and massive. So anything which is less than 4 mm, you don't worry so much. Okay, then the next question is to this thing, Dr. Manju. Doppler, what is the role of Doppler? Doppler of what?
Ultrasound Doppler is but nowadays it is a very non-invasive technique for diagnosing the fetal
Doppler of which vessel?
This is middle cerebral artery. That gives the.
Any other vessel you want to do?
These vessels pick up the very accurately the changes.
Any other vessel besides middle cerebral Doppler? I didn't leave it at just Doppler, you know.
Ductus
and all are very later on, you know. Yeah. What about What about umbilical?
Umbilical artery. Umbilical artery.
Are we doing? See, what are we worried about? We are worried about anemia. We are worried about oxygenation.
Oxygenation. So it is very important. Doppler is very important once the titer is above the 160 or critical level has achieved. So it will give the peak systolic velocity of the middle cerebral artery. If it is more than 1.5, then it is serious case as well category. If it is less than that, then we'll manage accordingly to the.
Okay. So you have a patient coming with a titer of 1 in 16. When will you do the Doppler?
Once that it is usually Doppler is done at the 20 weeks. We can do it, but
no. Patient is coming in 1 in 16. You don't know it is 20 weeks or what. He's coming with a titer of 1 in 16. Whether it is 20 weeks or 28 weeks or 30 weeks.
That's when you do it.
Let Dr. Manju and finish the. Yeah. So when is the time to do the Doppler of the middle cerebral artery?
It's 18 to 20 weeks, ma'am.
Once it reaches the critical level.
No. Let us go to the next person. It's next person, please.
You can do a baseline Doppler and then
Dr. Who's answering?
weekly.
Who's
Dr. Neeru.
Dr. Neeru, yeah, I can see you now. Yeah, so Dr. Neeru, you have a patient who has got a titer of 1 in 16, you said, no? We said that a patient will do Doppler when the titer goes above 1 in 16. So 1 in 16 can happen at any period of gestation, no? Whether it is 16 weeks or 20 weeks, or for the first time also it can occur at 28 weeks. So whatever time you get the ICT positive, you should do the Doppler or Dr. Neeru, if a patient is booked in the beginning and she is having a titer of 1 in 32, when will you start?
It's like salvaging the fetus before 22 weeks is very, very difficult. It's almost impossible.
I have done at 16 weeks also IUT. Patients had eye drops, what to do?
Then if the baby has intrauterine transfusions and then delivery.
Anybody wants to discuss this point specifically? We are not going up to delivery as yet. Yes, Dr. Rawatgi.
Yes, if the titer is more than 1 in 16, we feel that the baby is at risk, and we begin to do a Doppler every week. And
when? Starting when?
18 weeks. 16.
18 to 18 weeks, ma'am.
18 weeks.
See, I wanted people, let me explain here. It is the fetal reticuloendothelial system is not mature before 16 to 18 weeks. Okay? Because the idea that the baby's RBCs have to be immunized, no? So the maternal antibodies are coming, they're coming from the beginning in an immunized patient who is immunized before the previous pregnancy. Even at 12 weeks, 14 weeks, the baby is getting this thing. The antibodies are coming from the mother to the baby, but because the immune system is not ready, is not mature, so the baby's spleen and the reticuloendothelial system cannot destroy the baby's own RBCs. Okay, so that will be only after 16 to 18 weeks. So we have to start monitoring from 16 to 18 weeks onwards. But there are some things, like I have seen variety of cases. There are patients who have been referred with high drops at 16 weeks also. So in those cases, I'll start much earlier. Don't know how, but 16 weeks also, 18 weeks I have done IUT. So once a patient has reached 16 to 18 weeks, we start doing the ICT in a patient who is isoimmunized. So next comes the question to, it was Abha answering. So Dr. Hemali, would you like to refer the case? I think, one thing we said is, who will do the Doppler?
Madam, can you repeat?
Dr. Hemali, the question is, we have the audience here also. So, audience can hear, no?
Yes.
What is the feedback? Audience are hearing properly?
But we can the feedback.
yeah, anybody's in the studio. I mean, audience can hear, na?
Yes, madam.
Yeah,
Audience
no
can
problem.
hear.
Yeah.
No problem.
Okay, right. So now the question is, the audience are mainly obstetricians. I think they're not fetal medicine experts. So would you like to do the Doppler yourself or refer?
Send her to a fetal medicine specialist.
Specialist, yeah, that's best.
I hope the message goes that as soon as you find that the ICT is positive, don't try to manage, because this is the index pregnancy which is the most important and the best chance of saving the fetus. Don't think that the next pregnancy is going to be better. No, it's going to be much worse. So this is the best chance, and we should refer to the right person who knows how to do Doppler. I still remember some of my friends, like Rana and all, we used to say, you can do the Doppler, you can give the report, anything you want. It is so difficult to do a Doppler of the middle cerebral artery properly. So I never realized, even some very, very senior people used to do it, and they will say severe anemia referred for IUT, and I used to do them and find that there is no thing, there is no anemia. Or, we take them for an IUT and we find that the hematocrit is 40. I mean, so a Doppler should be done by a very experienced person above a normal radiological experience, ultrasonic experience, So it should be a specialized person who's regularly doing. Not ultrasonologist, fetal medicine obstetricians. Why should it be given?
Fetal medicine specialist.
Yes, a fetal
Anybody
medicine
with good
specialist.
experience.
Yes. So we, obstetricians, we should be able to do ultrasounds ourselves. We should be also able to do Doppler. The fetal medicine expert is able to do that. So I wanted to stress, because there are so many factors, about doing the Doppler properly, the level of inclination of the probes, and so many things which give you very varying reports, and then you cannot manage. So many times in my experience, I have had patients who have been referred with raised Dopplers, but when we did them, we found that the Dopplers were okay, and we did not need to do IUT, we just monitored. So the take-home message is ICT positive, refer to an expert. If the patient cannot go immediately and all, then you find who is good, and then do. But general obstetrician should not take the risk of this pregnancy, because this is the best chance of saving the baby. Next time it is not going to be so easy. So the Doppler is now, the question goes to, I think, I'm getting confused. Shall we go to Dr. Neelam then? The middle cerebral artery is more than 1:5. What does it mean?
Pardon?
Dr. Neelam, can you see my slide?
Yeah.
Middle cerebral artery is more than 1.5 MOM.
Yeah.
So what do we do?
Now it is 1.5 mom. So we can do every 2 weeks. We have to do Doppler of middle cerebral artery.
More than 1.5 means what?
No.
More than 1.5. Sorry.
More than 1.5 MOM.
Fetal blood sampling.
It is more than 1.5.
Please, everybody don't answer. You will get your turn. One by one, and we brush up the cobwebs. So we are talking to Dr. Neelam.
It is more than 1.5, and so we have to send up. I mean, the patient is with the fetal medicine person, so we have to prepare for intrauterine transfusion.
Fetal blood sampling.
Now it depends upon the period of gestation.
Period of.
Does it depend upon the period of gestation?
Yes.
How?
Before 22 weeks, it is very difficult to carry out fetal blood sampling. So usually, after 22 weeks, we take up these.
What will you do if at 22 weeks she's having 1:5? What do you do?
I can't hear you.
At 1.5 MOM, 22 weeks. What will you do?
I'll just add on. Some people would go for an intraperitoneal the transfusion because that's
the expert will decide. Yeah, we can do. Yes, Pragya, we can do IUT. As I said earlier, I have done IUT even 16, 18 weeks. Intraperitoneal, we can do.
Yes.
Yes, intraperitoneal.
Because 1.5, you can't leave. Baby is having, now, there is a risk of severe fetal anemia and you can't wait. So it depends upon the period of gestation.
Recently,
Train transfusion is possible before 16-18 week? No, no.
See, as I said, before 16-18 weeks, the baby cannot usually be affected. But yes, I have done IUT even at 18 weeks. It is possible, and as Pragya said, intraperitoneal can be done. But
I was just listening. I had just recently listened to a talk by Dr. Suresh, and this is exactly what he was saying, that, around 18 weeks, they would start with an intraperitoneal transfusion, wait for a few weeks, and then, like say after 22 weeks or so, they would go for an intrauterine
intravascular. Yeah. So what we do is we try, we really magnify the whole thing. And if you cannot get into the vein, then we go to the peritoneal. So this is the scope of doing intra. It depends on the expertise and the skill. But okay, my question to I think it was Dr. Renu.
Yes.
That 34 weeks and ICT is Doppler is 1.5 MOM more than that. What will you do, Dr. Renu Rohati? 34 weeks.
Delivery of the baby. 34 weeks planned delivery of the baby. Give antenatal corticosteroids and take out the baby.
Okay, let us see whether Dr. Hammerly would agree for that. 34 weeks.
Yeah, 34 weeks with this scenario, I would like to deliver the baby because it is easier to manage extrauterine.
Everybody wants to do that?
Yes.
Yeah, anything you want to add here?
Antenatal steroids to be given.
Yeah, of course, she has already mentioned.
Antenatal steroid, RH isomalization, let me tell you, we can give it as soon as she's 28 weeks.
Is less than? Excuse me.
28 weeks. RH isomalization, this is a protocol we follow at AIMS. Every RH isomalization, we give prophylactic steroids at 28 weeks because you don't know when she's going to need. Okay. The question was 34 weeks, middle cerebral artery peak systolic velocity more than 1.5 MOM. Anybody who wants to add? Those who have spoken, no need. Anybody who's left out? Manju.
If it is 1.5, we can go for the fetal blood sampling. The hematocrit level is less than 30.
So you mean you will do IUT 34 weeks?
Yes, we can do.
Yes,
we can do.
That is what I want to say. We have done IUT even at 36, 37 weeks. Okay. Why do you want to have a premature baby? Now, it depends here also because this is a little higher level we are going now. I just want to say that earlier, I'm talking about 25 years back, as soon as the pregnancy reached 34 weeks, give steroid and deliver. And we were feeling so happy ki bach gaya. Okay. But we became more expert in doing IUT. We started getting better machines because those earlier machines, we used to say, we imagine more rather than imaging. We imagine, this is the God baby. Anyway, now we have better machines. We have very high resolution machines. We have become more expert. So we have started doing transfusions even at 36, 37 weeks. So we plan in such a way. Yes, we plan in such a way that the last transfusion will be around 35 weeks. Normally, we give transfusions every 3 or 4 weeks. The ones who have been transfused right from the beginning, 20 weeks, 24 weeks. So we plan the transfusion in such a way that she will get the baby, we get the last transfusion at 35 weeks, and then we deliver at 38 weeks.
Normally, people don't do it after 35.
Yeah. I mean, I have done it even at 37 weeks. If you think it is going to be easy, the cord is very nicely visible, then we take the risk. If the cord is posterior, the baby has oligohydramnios, we think it's going to be difficult, then we deliver. But with experience, you will realize when it is an easy IUT and when is it going to be a difficult IUT. The way you know that this is going to be a difficult cesarean, I must do it myself, I can't give it to my PG. It's like that. I know when I have to do the IUT and I can't give it to my Aparna. Is Aparna listening? So it's like that. Okay. Now she's become an expert also. So we have to do the we have to do the cord blood sampling with everything ready for an IUT. You must have the blood. As your needle is inside and you're saying blood abhi tak nahi aaya, you know. So you must have the preparation for IUT and do the chordosynthesis. Then after you've done the first blood sampling, you find out the hematocrit. Then you decide how much blood to transfuse. So it should be there. And normally what we do is that we keep the cesarean OT standby. We keep the cesarean OT standby anytime beyond 28-30 weeks, because if there is any problem during an IUT, we have to do an emergency cesarean. Any other tests you need to do? Do you do amniocentesis anymore?
Now,
do a lot of amniocentesis earlier.
Nowadays, before
middle cerebral artery, before middle cerebral artery came into vogue, then it became so accurate that you don't have to do amniocentesis for spectrophotometry. But the earlier obstetricians will remember that we used to do amniocentesis for spectrophotometry for bilirubin, which was an indirect way. Yes, it was an indirect way of knowing the
fetal affection.
Okay, so let us go to the next slide. So we have talked about the decision for IUT. Does anybody have any queries?
No.
Madam, can I add?
Yeah. Who's talking?
Hello?
Yeah.
Dr. Neelam. Yeah, I just wanted to
add.
Yes,
Dr. Neelam, tell me.
At 35 weeks, can we give intravenous immunoglobulins to mother to prolong the pregnancy for 1 more week or 2 more weeks?
Actually, immunoglobulins, intravenous immunoglobulin is better to be given earlier. If we give at all, we give in the early, because by this time, there is no, once the baby is immunized and it's reached 35 weeks, there's no point. We like to delay the onset. See, I told you about the serious cases where the previous babies have been affected before 20 weeks or so. In these are the cases we give immunoglobulins, IVIG, to the mother in the hope that the fetal anemia will be delayed beyond 22-24 weeks when IUT will be easier. Okay. The whole idea is to delay the onset of fetal anemia, not at 35 weeks.
What about when plasmapheresis?
Anybody has any experience?
No.
I also don't have, because they were used even before I joined AIMS, and plasmapheresis is not easy. You need at least 15-16 units of blood
to get that
the longest procedure, and now we have better, easier methods. So plasmapheresis we really haven't done. We haven't done at all. Shall we go to the next question?
Yes.
Okay.
Yes.
Now, timing of delivery. So I think the thing is gone. What is the timing of IUT we have discussed? So let us talk about the timing of delivery before we go to the newborn. So I think it's time for Dr. Neeru to answer. When you like to deliver the baby? She's not there. Dr. Manju?
I'm here.
Yeah. Dr. Neeru, I couldn't hear you. Yeah. So when do you like to deliver the baby of an RH immunized pregnancy?
We will like to delay the delivery as long as possible. We are giving, suppose we are giving intrauterine transfusion and we can maintain the hematocrit, then we will like to take the baby to at least 37 weeks. But if the things are not getting controlled and it is like too often it is being required, then we will have to go for early.
Too often? I couldn't catch you.
Yes. I was saying if it is like, if we are supposed to, suppose the baby's RBC destruction is very, very fast, and then we might have to go for early delivery, or if the hydrops is developing.
Hydrops, see, that will
Hydrops is
happen.
already there. Means hemoglobin is dropping very fast. And
Why should the hemoglobin drop fast?
Because of destruction.
Why should it be destroyed? You're giving blood. You're giving O negative blood. The scenario that you're talking is about hemolytic anemia of the baby because of other causes, not RH. So if you're giving blood, you should give during the transfusion adequate amount of blood. You should not give less. Some people I see that, they give less, they feel scared to give. I always over transfuse. There are lots of literature where they say that whatever you calculate, you can give more. If you give at the right amount of blood, transfusion is not required before 3 or 4 weeks. We do the blood transfusion in such a way that the post-transfusion hematocrit is around 50 to 60. So we calculate that the fall is about 1% per day. So if it is 60, it will take 30 days to become 30. Okay. So we give blood transfusion only after every month. So you should do the transfusion properly. You should not just give conducive blood, give full blood. Oh. And then you don't require, just like in an anemic patient, you give blood. And then you don't require, it is an adult patient inside, just think about an adult patient and you think about this baby inside. So if you give adequate amount of blood, you don't have to give too frequently. Very rarely because of some other condition.
One thing I ask, ma'am.
Yeah.
If the patient has in previous pregnancy has hemolytic anemia, in this condition, in past pregnancy, she had developed severe hemolytic disease.
Yeah.
Then termination can be done at 34 week of pregnancy.
Why?
Yes.
No, why?
As you mentioned, madam, if the previous pregnancy had the patient, there is more chances of developing the same.
Okay, so the baby had hydrops, let's say. In this pregnancy, now what is the relation with the previous pregnancy? The baby is now having anemia. You treat the anemia.
No severe.
You just
treating it.
It is severe. It is severe. That is why you're giving IT. You're giving transfusion. So don't get scared. You are giving blood only to the severely affected baby. You're not giving blood to a mild an adult. Do you give blood to a mild anemic?
No.
Think of an adult. When do you give blood?
Dr. Manju, that's why we are.
When do you give blood?
Hematocrit is less than 30.
You see, in an adult, you will not give blood until the hemoglobin is less than 5, 7. No. A pregnant woman, when will you give blood? Let me explain, so that you can understand. You give blood only if the hemoglobin is less than 7 or maybe, 8, 9. No. You don't give it when it is mildly anemic, 10.
No.
No. So like that in a baby also, you don't give when the baby is mild anemic. You only give when it is severely anemic. So if you are giving blood, you are treating. So why do you have to deliver early?
Yes, ma'am.
Okay. Is it clear?
Yes, ma'am.
Previous pregnancy, we are getting patients, previous 3-4 babies died of hydrops. And in this pregnancy, we don't let hydrops develop. See, there is a difference.
I just wanted to clarify.
Yes. Yeah, Pragya, please.
Doubt, I just trying to clarify Dr. Manju's doubt. She was, general obstetricians, they feel that, if there's a history of hydropic baby, say at about.
Pragya, louder, please.
I'm quite loud, I'm quite loud.
Oh, okay.
Can you hear?
Now you're better.
Yeah. So just clarifying Dr. Manju's doubt. Normally what happens that, general obstetricians, they feel that, if a baby has developed hydrops at 36 weeks, or 34 weeks in the last pregnancy. So then in the next pregnancy, you should actually try and deliver the baby.
Yeah, I understood. Let me clarify, Dr. Manju. Why did the patient have hydrops?
That's why
that is why
we are doing the titers, so that when you reach the critical titer, then
No. She is already immunized, so there's no reaching critical titer. She had a previous baby with hydrops,
so already
she's immunized.
She is immunized.
Now we are doing Doppler. Now we are doing Doppler. Previous pregnancy, they probably did not do Doppler. Okay, otherwise the baby would not have been hydropic. Now you're treating. Okay, so we get patients with previous 3, 4, 5 hydrops. I once had a patient with 15 hydropic babies. I can't forget that case. But in the index pregnancy, in this pregnancy, you have treated her from the beginning. Yes. You may give immunoglobulins, delayed the onset of anemia. From 24 weeks, you're doing transfusion. She had a history of hydrops at 24 weeks, let's say. Okay. And now she's reached 24 weeks. What you're going to do? You do IUT, na?
You are doing your.
Yeah. So now forget the past. You think about the present. In this baby, you will just monitor the babies with the post-transfusion hematocrit. And now we monitor her in addition to IUT. We do the middle cerebral artery. And then we do the blood transfusion when required, depending upon the post-transfusion hematocrit. If the post-transfusion hematocrit is 50, then it will fall at 1%. So by 20 days, it will become 30. So you will do the transfusion after 3 weeks.
Yes.
Yeah. So you do serial transfusions. So I have done even sometimes serial transfusions 7-8 times in one patient, in one baby. So, and the ones who come with hydrops, you can't give full volume of blood. You know, in those cases, we give 1/3 of the volume every alternate day because the heart will fail if you give full dose of blood.
Will go and fail.
Calculated blood. Yeah. Okay. So there is no need to do preterm delivery because the previous baby was hydrops. Because you're treating this time.
Yes.
But if the present pregnancy baby was hydrops at the time of referral, that baby is sick. You know, those are the babies we deliver at 36 weeks.
Yes.
Because they have a lot of body changes, no? Liver is enlarged, everything. The point is, don't let hydrops develop. Don't let very severe anemia develop.
Okay.
Give transfusion before that. Middle cerebral artery will help you to guide when to give the transfusion.
When to give the transfusion.
Okay. So then we now have the baby. We have decided when to deliver the baby. We deliver at term. You know, we like to go as far beyond 37, 38 weeks. We give steroids. We deliver the baby. Now, baby is handed over to the pediatrician, the neonatologist. So what will they do? Any pediatrician in the panel? We don't have that.
No.
Yeah, but pediatrician, the neonatologist is a very important part of the team. Many factors, anemia, and if it is hydrop, they have difficulty in breathing, you know, hypoxia. So what are the things? We said we will do hemoglobin, bilirubin. These are the two main things which will determine exchange transfusion after birth. So can anybody please tell us? Let us start again. Dr. Neelam. Role of exchange transfusion after IUT or without IUT in a severely affected newborn.
That will depend upon the bilirubin level, cord bilirubin level. If it is more than 4 milligram per DL, or if it is rising more than 0.5 milligram per hour.
One is bilirubin monitoring required.
Yes.
Most importantly is the hemoglobin.
Less than 10 gram or 11.
Less than 10 gram exchange transfusion.
So hemoglobin we have to give. Huh? So you
if
like to
less
give,
than 10.
And if the bilirubin level is rising 1 milligram per day per day, na?
Per hour.
Per hour.
One day is too long. 1 day is too long, right?
Per hour.
So you have to.
And total bilirubin level more than 20.
That's you don't let it go so high. Yeah.
In 24 hours.
So and then some people are giving immunoglobulins also.
Yes.
And then exchange transfusions we are doing that we are. So then we also monitor for the other things like the chest. So I think first of all, let me ask if there are any questions from the panel. I think we have covered most of the things. Yes. So what would you say like about terminating a pregnancy because of RH isomerization?
No.
No.
I know. I'm so happy. I have had patients referred for termination.
No.
So we should try. We should try to save.
Dr. Deepika, I remember that in a very old textbook when we were students, it was written that sterilization was the ultimate answer. And now
actually, yeah, very good. I forgot to tell you this.
And now it is so
adoption is the last choice.
Say no to a lady.
Yeah.
And adoption is the last option.
Yeah. See, I had a patient before adoption. There is another thing. I'll tell you. Anybody wants to add? Dr. Manju said adoption is the last option. There is a second last option also. Anybody?
Last option is IUI with a negative.
Absolutely. I had to do one patient and I advised her IUI with an RH negative donor. You know what happened? It is a joke. He had IUI with an RH negative donor and was having intercourse with a husband also.
Conceived with husband.
Conceived with husband. So you must counsel that husband should use a condom.
Stay away from the husband.
Stay away if possible, otherwise use a condom, because we did IUI with an RH negative donor and we told her, but husband said why, and he did not use condom and we kept on having RH positive babies. She had very early, I
like good news.
She had very early pregnancy, high drops, very early high drops. I tried IUT, could not do, so I said 2 pregnancies I did like that. I said, bahut ho gaya. Next time we do IUI, they agreed. But as I said, husband was not using condom and she came back again with RH positive baby of the husband. I think we had a very interesting discussion. I don't know whether we have short the time. So I'm going to have some questions from the audience. Please.
Yeah. So now
I would just like to add one thing just before questions, that while we were talking of intrauterine transfusion, so there is a calculator which says that how much blood should be given in.
Yes. We have a formula, Bandrod's formula, wherein we take into consideration. Anybody wants to say? Wants to say?
Yeah. I think the formula is desired hematocrit minus the patient's hematocrit. The formula is desired hematocrit.
Yeah. What are the components in the
Target
formula?
hematocrit.
The hematocrit of the baby, the hematocrit of the mother, the hematocrit.
No, not mother.
No, not the mother.
Not the
Donor.
Placental volume
Blood
and the
volume. Yeah.
And important is the target hematocrit, what you want.
Yes.
The target.
What is the target hematocrit that you want? We talked about in discussion. But if message to go through to the audience, what is the target hematocrit after an IUT?
50%.
See, 60 you said just now. So that's
55 to 60. I know. There are reports where you give over transfusion, but let us start. Let us talk about what is normal. So we should go at least up to 55.
55.
Yeah.
50-50.
Yeah. Then because we do transfusion when the hematocrit is less than 30.
Then
So if you make it 55, you get 3 weeks aram se, even 4 weeks. So that you decrease the frequency of the If you give very less and the hematocrit after your transfusion goes from 25 to 40, then you will have to give transfusion after 2 weeks.
Yes.
And if you give more, you will have to give transfusion after 3 weeks. Each transfusion is a risk.
But there are chances of more
the risk. The needle going into the cord is a risk. There can be bradycardia. So decrease the need for transfusion.
Yeah. Dr. Decker, just a couple of things. One is like something good, that we already have more than 300 viewers. So that's nice.
Oh,
and
wow.
And secondly, now you can stop sharing your screen. On top you will find stop,
Yes, I forgot.
Yeah. And what I'll do now, I'll start, reading out some of the questions from the audience.
Please.
Yeah.
I have a question, Dr. Decker. Is there are you all doing a prenatal fetal digital cell-free DNA to find out the RH status of the?
We had a PhD. We were doing expensive. It is not standardized.
I think it's
one thing more. Since we are talking about the higher advances, if I'm doing an amniocentesis for a case of to rule out Down syndrome or something else, or doing CBS for thalassemia in an RH negative patient, I take a little bit of tissue and I do the baby's blood. We can do the baby's blood group from amniotic fluid from CV tissue, and if you know it is negative, then you're not worried. But it has to be done from a good lab.
Right. Very nice.
Now,
It's very
reading out some of the questions from the audience, but actually, most of it we have discussed during the panel, but never mind, I will read out. There's a question from Dr. Anju Kumari. She has asked, is anti-D advisable for pregnant patient who is diagnosed RH negative during antenatal care? So, Dr. Anju, we have already
The idea is that. The idea is that.
Yeah. So every patient, who is RH negative, we have to give her anti-D in pregnancy. So prophylactic anti-D in pregnancy.
28 week of pregnancy.
Provided negative, ICT negative.
Provided patient is not immunized.
Yeah. So of course you have to distinguish between active and passive immunization. That is also important, and that depends on the history that you have taken. Now, I'll skip. Somebody has asked a question about RPL, so I think I'll skip that because our focus is
RH.
Something went wrong. Something went wrong.
Pragya's voice is breaking.
Or something.
Can I hear Pragya?
Okay.
Pragya is missing.
All of you are in your homes.
Yes.
Yes. In the.
Pragya, where is Pragya? She's in the studio. Where's she gone?
She's also. She's not seen.
No, her voice is also
not. Interconnectivity must
not audible, not visible.
Somebody, where are the organizers?
She became the ghost cell of RH negative.
Organizers can send the questions to you.
We have Dr. Pragya coming back online. Madam, you're muted.
Who is muted? Me. No.
Dr. Pragya is currently muted.
Okay.
A mistake.
Oh, unmute yourself.
So can you read out the questions?
Yeah.
Can you put me on full screen? Okay.
Yeah. I'll just repeat the question. This is a question, quite a basic question from Dr. Ritu Kumari. She's asking who should we give the prophylactic dose of injection Rogam, well, she means anti-D, in the antenatal period of RH negative women. So who should be giving? So Ritu, we have to give
all RH negative women.
All RH
negative. No, ICT negative. ICT negative.
ICT negative.
ICT negative. That has to be added. I think this is the basic mistake everybody is doing.
Yeah, I think what she's asking, I'm just thinking.
Who will should
she's
give?
probably
Doctor,
asking
nurse, or
whether
someone?
we should give to the multigravidas who will not have children later on.
I think who should doctor, nurse.
I have had some questions once in a panel discussion, but this is prophylactic for next pregnancy. Can I have myself full swing? Oh, so organizers, can I have myself full swing? I want to take a photograph actually. Okay, the thing is, I have had patients who had ligation, who had recanalization, and then she was isomimmunized. And her pregnancies after that, where IUT had to be given. Because she did not give anti-D in the last pregnancy. But this is, of course, going to be very, very rare. But sometimes in the third
it is better to give them.
Second pregnancy, you don't want any more children, they don't have money. These are some things. But theoretically, every RH negative woman, ICT negative. And next question, Pragya?
Yeah. Well, she has asked, the same person has asked, what is the criteria and what should be the dose?
We have already discussed.
We have already discussed.
Let us go to questions we haven't discussed.
Yeah. So most of the things have been discussed, So the RH antibody titer, when to do, how to interpret and management. Dr. Pushpa
already
Singh
discussed.
We have discussed that, but Dr. Dekka, please repeat it for the convenience of the person who has asked.
Yeah. What was the question? When to do?
Yeah, so she's asked when to do and how to interpret and manage.
How to interpret? Okay. Pragya, can I have full screen? I just want to take a photograph of myself.
Yes.
For memory. I mean, the organizer will have to do. Organizers? Okay. They have not heard. Okay. Whoever's asked a question, audience, they can hear, na?
Yeah.
Yes, very nice.
Negative patient at the time of booking, and after that, every 4 weeks till the anti-D injection, prophylactic anti-D is taken. I'm talking about the routine cases, and if they had any time, any intervention like CBS or blood center for any other thing, they had threatened abortion, they had placenta previa. In those special situations, they may need anti-D beforehand. Okay. The second thing is how to interpret. So if the ICT is negative, it's good to go ahead with the ICTs done, as I said. If it is positive, if it is very low titer, you are worried, you have to do the ICTs every week because any time they can increase. ICT 1 in 4, 1 in 8, repeat every week. And if it is reaching the critical titer of 1 in 16, then you have to start fetal monitoring. You have to start fetal cerebral artery Doppler. You have to start doing ultrasound for everything else. And you should preferably refer to a fetal medicine expert who has the expertise of doing Doppler and the expertise of doing intrauterine fetal blood transfusion.
Madam, one thing can I ask? Is there one thing, any difference between the primary patient and multi-patient for the monthly checkup of?
No. It is the
same 1 month interval. 12, 20.
See, primary, there is less chance.
Yes.
There is less risk, but it is not without risk also. So you may be a little, it is lower risk,
but risk.
But yeah. Same thing with the multi also, no?
The monthly one. Okay, ma'am.
Next question, Pragya?
Yeah. So next question, basis of RH immunization. Well, we all that, why, we are doing all this and we are giving
basis of RH immunization.
Yeah.
Want to understand pathogenesis?
I don't know.
I think the pathogenesis of RH immunization. Any panelist want to answer? कैसे बनता है RH?
Yeah.
Whenever an RH negative mother carries an RH positive
what
fetus,
is important over here that I think Dr. Poonam Raman has asked this. Well, if the mother is RH negative and the father is RH positive, then and depends on the zygosity state of the father,
which we can't do.
Whether the father is heterozygous or homozygous. If the father is homozygous for the D antigen, there is 100% chance that the fetus can be RH positive. Yeah, and whereas if the father is heterozygous, then there is 50% chance that.
Yeah, but the problem, here, I think we should not tell this audience about heterozygous because we don't do.
I'm just relating everything.
Yeah.
Now, if the baby.
your voice has stopped, Pragya.
We cannot hear.
There's some problem with her net connectivity.
There is some problem with connectivity.
Is anybody there? Hello? We can't hear anything. Something's wrong with the connectivity.
No, we can hear you. We can hear you, Dr. Deepika. We cannot hear Pragya.
Only Pragya.
Hear each other.
Okay. And can you just put me for a little while on full screen? I want to take a picture.
Unmute yourself.
Unmute.
Unmute.
I think her net is not working. Her connectivity is poor.
No.
Pragya, you can make it on the phone. You can phone me.
No, it's fine. Is it better now?
Yeah, now we can hear you.
Now we can hear you.
Yeah.
Yes, we can.
Yeah.
Not visible, but.
Yeah.
Now
Next question.
Yeah.
So
Next question.
Yeah. So that was answering, the basis, of this thing. Right. Now, actually, there are many questions, so I'll rapidly go through them.
Yeah, just screen the questions. The ones which have been answered, we don't need.
Yeah. Now,
What time are we finishing?
There is no time limit, as such, whenever we want to wind up, we can.
Yeah, actually, I have to go somewhere. Yeah.
Yeah.
I thought 1:30.
1:30 was the time. 1:30 was
Yeah.
It's already 1:40.
Yeah.
Panel
So let's just wind up in 10 minutes, huh?
Yes.
Yeah. So what is Dr. Mamta Singh has asked, what is the incidence of RH incompatibility in our state? Mamta, we don't know it actually.
No. Let me answer.
We don't know. But otherwise, yeah.
So I think that's a very nice way. You can go to one of the blood banks.
Yeah.
That person, whoever's asked, I think it's a very good point for you to do research. Go to a blood bank and then find out. But generally, in India, it is about 5%.
Yeah,
10%. North is more, south is less.
Yeah. And average, even during pregnancy, this fetal-maternal hemorrhage, it's usually never more than 4 ml.
It's very low, but it happens mainly after delivery.
And the incidence also
during the delivery of the placenta.
5%, almost 9%. They say that just about 1% or so.
It is about 15%. If you have 100 RH negative women and you don't give anti-D, 15% only will become immunized. Some natural immunity and the rest 85% do not get. So out of that 15%, if you give the anti-D, then it becomes much lesser.
RH incompatibility between husband and wife also works over here.
ABO incompatibility. No.
ABO.
Baby with ABO incompatibility, baby and mother.
Yes. Yeah. You can explain? Because the
mother has
those will become
antibody against that.
Hemolyzed, so they are at low risk.
Positive. So give protection against that.
Yes. Next question, Pragya, where are you?
Pragya is having problem with connectivity.
Today. I think last few times my Wi-Fi was working wonderfully. आज लग रहा है कि नजर लग गया है, and I think there's a problem today, literally. And last few times it was wonderful.
Two laptops.
My Wi-Fi, I'm so happy is working because it is very like raining cats and dogs outside.
Yeah.
Oh.
Now,
next question,
Dr. Lakshmi Gogoi, I think Dr. Dekka, you must be knowing her. She has asked how professionally we can handle a labor case. I mean, I can't. Does she need to? I cannot understand what she's wanting to ask. She's asking how professionally we can handle a labor case. I think
that's
that's what probably she means.
Okay, how can you deliver a patient? So I think the timing of delivery we have already discussed. Second thing is how we should deliver. Okay.
The precautions
many people they think that if you do so many transfusion, it is a very precious pregnancy. You should do an elective cesarean. I want to surprise you by saying that these patients, we let them have normal delivery. They are multis and they deliver very quickly. Unless the baby is anemic, unless it is very, severely premature, of course, and also unless the baby is very precious, the parents don't want to take the risk. then we do the cesarean. Otherwise, there is no obstetric indication that you should do a cesarean for an RH isotonized baby, whether you have given transfusion or not. No, earlier, transfused babies we used to do cesarean. Now we don't. We let them have normal. So we understood that the basic pathology is anemia. So if anemia is treated, then the baby is normal. So let them have a normal delivery unless there is an obstetric indication. So I think that is what she meant by the thing, delivery, yeah. And the timing of the delivery, we have already told you, Dr. Gogoi, we have already told you. And the mode of delivery, the precautions that you have to take is that you have to do early clamping. Early clamping, don't do manual removal of placenta. And hand over the neonatologists have to be there because these babies have to be seen by expert neonatologists for anemia, bilirubin. So they should deliver in a hospital with tertiary neonatal facilities.
Yeah. And there's a question from Dr.
The cord should be kept off because maybe the child needs transfusion.
Yes. At least 6 inches. 6 inches, we must keep it long.
Yeah. Now, there's a question from Dr. Meena Samant. Do you suggest quantifying the FM, I think she means the fetal-maternal hemorrhage, in some high-risk conditions? So, Meena, I'll answer that question. Now, basically, well, it is ideal to do that. But, but somehow, so many times in our scenario, it's not so easy to go for the Clio-Betke test. And, as we mentioned initially, that, 300 micrograms of anti-D is enough to cover, 15 ml of hemorrhage. So, which is quite a lot. An average, it's just about 4 ml. So, you can understand 15 ml is quite a lot. So, if you're giving 300 micrograms, you can cover it, very nicely. So, our preparations, 300 micrograms, that way they suffice. But ideally, if you have the facility in your hospital and somebody can give the results, soon, so which would mean that if you've given IM anti-D, so within 72 hours, if you can get the results, of the fetal-maternal, how much of blood loss or, is there. So in that case, you can actually give her more anti-D. And more anti-D, it would mean that for 1 ml, you need 125 international units, which means about 25 micrograms. So any extra 1 ml of loss, you need an extra 25 micrograms. On top of that, the 300 micrograms, which you have given. So if you have the facility, well and good, you can do it,
Meena, I can just add to this. That what she's asking is that if you don't have the facility, then what to do? So there are clinical ways by which you can determine. So cases where you have had to do manually removal of placenta, it's a big placenta, you had to cut through the placenta, you can give double dose. You can safely give double dose.
Yeah.
Next question, Pragya.
The next question, someone has asked Dr. Sunil Mishra, are we advised Clio-Betke test, for estimating fetal-maternal hemorrhage? So that's
when you're suspecting.
Going back, yeah. So it would be ideal to do it. When I was in England, we would do it for all patients.
Actually, it is not difficult. It can be done. It is just an acid elution technique. All you need is a microscope and some coloring agents.
Yeah. Now, there's a question from Dr. Krishangi Kashyap. I want to ask, can cesarean section reduce the chances of erythroblastosis fetalis? So, I don't know why she's...
No. Let me answer this question. I think she's got her concepts all wrong. Cesarean section versus normal delivery? No. You why should you do cesarean section for an Rh negative patient? Is not indicated. Let's finish it at that.
Yeah. So
I just want to say one thing. Once we are doing cesarean, then we should do the packing properly so that the peritoneal spillage of blood is less and the sensitization is less later on.
Yeah, and the cord, should be allowed to hang low. It should be, the blood should come out. You should not give injection methergine, ergometrin, because let it come out on its own. Because if the cord is, don't clamp the maternal side of the cord. It is not going to cause PPH.
Okay,
That will flow out. It is the blood which is in the
management of
placenta
third stage
and the
labor
cord.
should be avoided.
Yes, yes.
Yeah.
Now, so certain precautions should be taken at the time of the delivery.
Yes.
Now the next question, I think because the panelists were not clear in answering one of our questions, that's why somebody has asked again, I think it's from Dr. Maninder Ahuja, has asked final, what is dose of anti-D at 18 weeks pregnancy? At 18 weeks. Well, as
150 microgram routinely.
Yeah.
But we don't have it.
Yeah,
it's not available very rarely, so we give full dose.
Yeah. But RCOG recommends about 250 IU only, which is about 50 micrograms.
Standard as well, we give 50 to 100 and then 150 and then 250.
Well, we have. I'm just, just rapidly go. Someone has asked how frequently, ideally, ICT should be done. We have discussed that. Dr. Farzana, we have discussed that. Dr. Deepika Decker illustrated it quite nicely. Now, if a patient comes with USG report of blighted ovum, are we going to give anti-D or not? That also we have discussed.
Blighted ovum we did not discuss because here there is no fetus.
There's no fetus. If there's no instrumentation, you can just leave it. You don't have to give anti-D. If there's no instrumentation. That was the question from Dr. Chanchal. Now, question from Dr. Nibha Mohan. What benefit with 2 doses of anti-D? So that, he's asking that why, probably Dr. Nibha Mohan means to ask, why do we give, 1 at 20?
1 versus 2.
Yeah. I already discussed that, see, for our scenario, Indian scenario, if you're giving between 28 to 30 weeks, 1 dose is enough, which is 300 micrograms. The people who actually, make the guidelines, like, some RCOG guidelines and international guidelines, because for them, 300 micrograms is not so freely available. That's why they recommend, giving a lower dose and 2 doses, 1 at 28 weeks and the other one is 34 weeks. Otherwise, it has no added advantage.
There is no difference actually. And in fact, our patients will come once, so better given full shot once.
Yes.
There's a question, if baby is negative, why do we need to give anti-D post-delivery, ma'am? Someone has asked.
We don't give. We don't give.
Yeah.
That's why we must get the baby's blood group as soon as possible.
Yeah, that's why
Father is negative than baby.
The hemoglobin, bilirubin, and the blood group of the baby. And if the baby is Rh negative, you don't have to give. Now, in twin pregnancy, both babies are positive. Should 2 doses be given? Someone has asked. Whether so.
Chances of fetal matter more.
I wouldn't give 2 doses. I don't know what is your opinion, Dr. Decker, on that. What is your take on that?
Actually, it was not very clear. What was the question?
No, the question was
twin pregnancy.
In twin pregnancy, both babies are positive. Then should you give 2 doses of, prophylactic anti-D?
No, we are still giving 1 unless, but because it is a bigger placenta, then and if you are doing a manual removal or something, there is a higher chance of increased fetomaternal hemorrhage. So you may think about that, but as a routine, we are not advising.
Yeah. Now there's a question from Dr. Seema. Patient had anti-D injection at 34 weeks. She went into preterm labor and delivered within a week. Post-delivery dose to be repeated. Now, Dr. Seema, normally they say that if you're giving, say, at 34 weeks, the patient is already covered for a sort of 6 weeks.
Postpartum.
Yeah. So, in that case, if she has, delivered within 1 week, I wouldn't repeat the dose of anti-D. I feel like, so that would be my answer for that.
I think 3 weeks. 3 weeks is more within 3 weeks.
Within 3 weeks.
More than 3 weeks, you better give.
Now, someone has asked, do all primary gravidas need to be tested for ICT routinely? Yes, at the time of booking, you have to, when you're checking a blood group, you have to do an ICT, that time, an indirect Holmes test.
We already talked about how the first pregnancy could be affected.
Yeah. Now, what is the time to give anti-D and we have discussed? What is the dose of anti-D in twin pregnancy? We just answered. Should we give anti-D in threatened miscarriage without pain and no bleeding? So again, Dr. Decker had mentioned in the beginning, because, if you're not very sure, then, you might as well not take chances and give her the dose of anti-D. But, going by RCOG guidelines, they would say that, if there's no instrumentation and there's one single episode of bleeding, there's a threatened miscarriage, in those cases, you need not give any anti-D. But I mean, most of us, I think, would go ahead and give anti-D. Right. And then how to proceed in Coombs test positive mother at 20 weeks. We have again discussed that. Yeah. Then do you people have any list of such clinically significant antigen donor list which can help during transfusion if required for these patients? Donor list, I mean.
No. We have.
But they have to go on the website, and
every like hospitals. Can I just answer this? Okay.
Yeah.
Because our hospital, because we have a lot of these patients, we have, and sometimes we have had to call them up also emergency for a blood donation. Blood banks know all that.
Now, if a case of APS,
I can see one question, very interesting. It just went off. It came on the screen. Somebody asked that if there is a history of a patient with many hydrops and what pre-pregnancy care. I would like to answer this question. Sundaram asked.
Yeah.
Okay.
Yeah.
The thing is that when there are so many hydrops, as I said, we've had patients with 3, 4, 5, 6 hydrops, they come in. So you know that the earliest period of gestation when the baby had affected, the next pregnancy, the affection, anemia will occur 6 to 8 weeks earlier. So these are the cases we give IVIG. Prenatally, people have given steroids and things like that, plasmapheresis, no use. People have given Phenargan, so many things. They're of no use. What we do is that as soon as they are booked for the pregnancy, so before 12 weeks onwards, we start giving IVIG immunoglobulins. We give, because they're very expensive. So what my research work, we give 5 to 10 grams every 3 weeks till they went on. And then we found that the babies were affected much later and they were bigger enough for us to manage by transfusions. Many such cases, our data are all published.
There's a question that if there's an APH, I think that also we discussed, if she bleeds off and on throughout the pregnancy, how many times she requires anti-D. Again, if you're giving her...
Every 3-4 weeks you give. Yeah. Because we said the mean activity is between 3 weeks. Though the half-life is longer, you can repeat after every 3 or 4 weeks, depending on the blood loss.
Someone has asked, again, calculation of dose of anti-D to Rh negative mothers after delivery. We said that, you give a standard dose of 300 micrograms, but if you're suspicious of, any more than if you think there's a large bleed, in that case, as I mentioned, that, for every extra 1 ml, you need about 25 micrograms of anti-D. So that way you can calculate. Now, is it necessary to do indirect Coombs test for multis if they have taken anti-D injections for previous delivery? We would still do it at the time of booking.
Of that.
Yeah.
Pardon? What is it?
Someone has asked, that is it necessary to do an indirect Coombs test for multigravidas if they have taken anti-D injection for previous delivery?
Of course. Yes.
Yeah.
Yeah, in fact, from my experience of more than 1,500 RH hospitalized, these are IUTs. So I must have seen more than 3,000 RH negative women. So many of them, most of the affected ones have received anti-D. I don't know whether it is the storage, the cold chain, whatever, why it didn't work. Most probably, we did a study also on that. What was the precipitating factor? So some of them were no anti-D given was the biggest one group, and of course anti-D given, but probably inadequate. How did they become? So in them we found manual involved placenta, cesarean sections, and all these things. Twins also we found.
Yeah. Someone is asked, do we give anti-D after delivery even if patient is ICT positive? Does it give slightest protection also even if ICT positive?
And this is what we said, absolutely not. This is a woman who can actually be a donor for making immunoglobulins.
Yeah, and
immunoglobulins are made from Rh positive, Rh immunized donors.
Yeah, and one more thing I would add, at suppose at 28 weeks, if you're doing an indirect Coombs test, better to do it before you give the dose of anti-D to the mother, so that
it is a routine.
Yeah, so that you know whether it's an active or passive immunization. Again, is it necessary? A lot of questions are related, calculation on the dose of anti-D and things like that. What about NTP pills? Negative patients, is it mandatory to give half dose of anti-D injection? So,
according to the period of gestation, you have to give them, and it is better to be given before you start taking the pill. The same day that you start taking the pill, because she can abort at any time.
Yeah. Now, the intensive management of anti-D, someone is asking. I think we have already discussed,
Yeah, we've discussed. Can we go to the next?
Yeah. Does vesicular mole, missed abortions, blighted ovum, ectopic pregnancy, less than 5 weeks need anti-D prophylaxis? It all depends. It's all because they are under.
Yeah, vesicular moles don't have blood. So, that is what is theoretically, but again, there is controversy whether you should give anti-D, but I feel that there is no fetus, there is no placenta. I mean, there is no need. That group is not.
So, someone has asked that how do you explain blood group report saying weakly positive?
Weakly positive are the ones which are very less titers. So we don't have to worry too much about them, but we have to monitor them more frequently. We have to do the ICT now every week instead of doing every 4 weeks.
Yeah. And how to diagnose severity of sensitization if anti-D has not been taken? We have already discussed that.
ICT. When you do the booking, you find that the ICT is 1 in 16 compared to another one. I have got patients with ICT of 1:4,000 something. Obviously, the one with a very high titer is going to be a higher risk.
Then
but even at 1 in 16, baby can develop hydrops.
Yeah. And one more thing, just for the audience, I wanted to mention, like some patients, like the ones who are, some would be Rh negative and some would be like, weakly Rh negative. So those patients also, can actually develop antibodies, those patients also. Now, is there any role of anti-D for Rh negative women with Rh positive baby after she has been tubectomized? Well, not, but bearing in mind that in future, if she wants to go for recanalization, you can always give her because you never know the future. So that way, you might as well, give her.
If they can't afford, I won't pressurize.
Exactly, and that you already covered, Dr. Decker. You mentioned.
I had a patient who was immunized after recanalization.
Yeah,
I mean, she was, of course, immunized and then she had a recanalization.
But actually, many patients, they say like that. And husband also wants to save on the anti-D and they say that this is the last we are going for ligation. So we don't want to get anti-D.
Again and again. I think it's okay. It's so expensive. We should tell the drug companies to decrease the price.
The price.
So we have come to the end of this highly interesting and interactive panel.
I enjoyed myself.
Yeah.
Thank you so much, Pragya, for
inviting me. Pragya,
I am so sorry for the situation. I could not do last time.
Please go ahead. Please go ahead.
It's been really a problem. Yeah.
I'm so
happy to be with you all. Yeah.
Dr. Deepika, the last question from my side. It was very informative, very interesting. We really enjoyed it. One thing, suppose if a patient, she had a hydrops in a previous pregnancy and this time she comes for an antenatal checkup, should we rely on the antibody titers or we'll depend on the MCA PCV for monitoring the fetus?
Antibody titers are no use. Once
Or of no use. I wanted this message to go.
Once it becomes 1 in 16, don't repeat.
No.
Once,
Suppose she had a
subsequent pregnancy,
severe hemolytic anemia.
subsequent, no
need of that.
So this
monitoring
follow up the patient with
So
USG.
this message should go to the audience that if she already had a severely affected fetus, then there is no role of antibody titer in the
whether severe or less.
Correct.
Once the titer is 1 in 16, it is affected throughout her life.
We answered, when Dr. Manju had a query, then, we already answered this, Abhadi. And Dr. Dekka elaborated that time that, she's already, sensitized. I mean, she already have a titer.
I think just for the benefit of the audience, I wanted this to be repeated for the benefit of the audience.
Okay, thank you so much.
Once a person is ICT positive, no role of repeat ICT,
One
no
question,
role of
ma'am.
LTD.
One question, madam. If the baby was severely affected, it is necessary that her titer will go up to 1:16?
Yeah, without the titers coming, how will the baby get affected?
You're right.
Yes.
In the last pregnancy.
Before ending, I would just like to say it was really very good, and I am RH negative with a positive husband.
What about your kids? You must have taken NTD very religiously.
To all this many times.
You must have taken NTD at 28 weeks and you have taken all the precautions.
Yes.
Let me also just
Evidence based.
I think it is over, but we can talk about I am
What is your experience?
my mother and
twin babies. Once Dr. Neelam had twin
father
children.
are both RH positive, but
she
my
has-
younger sister is RH negative. So how is that possible? How is that possible?
What?
My mother, father both are RH positive. I am RH positive. My two brother sisters are RH positive, but my youngest sister is RH negative. How?
Yeah, it can be if the parents are both heterozygous.
Yes.
Same with me. Same with me. I am only RH negative in my family. My three brother and sister, they are all RH positive. My father RH positive, my mother RH positive.
Both the parents.
So we used to tell my sister that you were picked up from the drain.
So we are to the end of this highly interactive panel on RH alloimmunization, best practices and guidelines. I'm sure that our viewers would have benefited, and we had hundreds of viewers today. I think
350. 350 is what is coming.
Yeah. And I think, one reason was because, Dr. Dekka, you're reconnecting with us,
I'm feeling so happy. I've been missing.
Yeah. See,
I have been missing. I'm doing other sort of, video conferencing. I was not doing this because I was thinking, but I think it's high time now that I should come back to obstetrics.
Yeah. That's why, I wanted you to reconnect with us. So a big thank you to Dr. Dekka, for having spent a valuable time in spite of the fact that she's a vice chancellor in Guwahati and her schedule is hectic. Still,
it's hectic because of the COVID. Otherwise, not so hectic.
Yeah. And I'm naming each one of the panelists to start with our president, Dr. Neelam, Dr. Abha Rani Sinha, Dr. Himali Sinha, Dr. Renu Radki, Dr. Neeru Goyal, Dr. Kumari Manju. Let me tell you, viewers, they are all professors in their own medical colleges. So we had a real, and of course myself, I'm the immediate past chairperson of Genetics and Fetal Medicine Committee of FOXI. So I hope that, all of us together have done a big justice, to this program.
I can see the comments and I think they have been appreciated.
Yeah. Lots of congratulations.
Thank you to the people who have given the
Really enjoyed it. It was a very nice discussion.
Yeah.
Thank you, everyone.
Thank you, ma'am. Dikha ma'am.
Dr. Deepika.
And we are very well within time also.
Thank you,
because
Dr. Pragya, for inviting us.
The time was up to 1:30, but questions we were about to take for 45 minutes, and it's just about 10 past 2, and we have finished. So that's
okay.
good.
People must be hungry now. Yeah.
Yeah. I know, because that's what, and to my Patna Obs and Gynae Society, attendees, I would again say, well, still waiting to catch up when we have our physical meetings. So good lunch and sumptuous lunch later on. Once,
you're missing that.
Yeah, really. Because, that physical interaction and the sumptuous lunches that we used to have at Moria Hotel, all that is gone. And, I'm missing my members also. So hope this COVID pandemic is over very soon, and just hope, keeping fingers crossed. So thank you very much to each of the panelists. Thank you for your
Thank you, Pragya, for such a nice panel discussion. Thank you,
Thank you so much.
Okay, thank you.
Thank you, Dr. Pragya.
Thank you. Bye.
Pragya, bye.
Bye.
Bye, everyone.
Bye.